Okay, guys, good morning. This is Dr. Bashura. I'm from the Greater Houston Oral Surgery Group. I'm going to run you guys through a case. This is a 50-year-old female that came in, and she has a bad tooth. And this tooth just broke off at the gum line. It's this tooth right here. She's very pretty and has a very high smile. So meaning when she smiles, she shows the gum here. And managing this case, especially from a soft tissue perspective, is very important, because if you don't get the soft tissue right, or even the implant position right, it will be very anesthetic. And when you're done, the implant sometimes will end up showing through here. In this area, you'll see a grayness of the implant. So managing this case correctly is very, very important. So moving on, once you take the crown off, this is what you see. And obviously, unfortunately, when these teeth break off like this is a root canal treated tooth, and she had a post and it broke off, and there's really not much left to the tooth in this area. So once you have no tooth structure above the gum, this tooth just needs to come out. Unfortunately, that's the way. And so I'll show you how we manage this case. And again, the pictures are cartoonized on purpose. So this is what the site looks like. We remove, this is just to orient you, we remove the gum off the bone. And so this is the bone right here. This is the bone level, and we remove the tooth. So now we have just a hole. We're going to put a little dental implant right in this area here. This is what you call an immediate implant placement, meaning we take the tooth out, we put an implant, and once the implant goes in, we'll graft around it, and I'll show you what that looks like in a second. This is an angulating pin. When we do these, we actually drill a very small hole, and we put a little pin in there to make sure that it is perfectly centered, and it's perfectly positioned. The implant platform should come out from this area here. This is called the cingulum of the tooth, and for anterior teeth, the implant platform ideally would come out through here, and this is what we're trying to achieve in this area right there. Moving on, this is the implant platform, and as you can tell, the implant is here, but there's a lot of space between the implant and the bone. You can't just leave that like that. You definitely have to fill it with bone graft. What we do, actually, we fill this whole area with human cadaver bone. It works extremely well. It doesn't have any tissue in it, but what happens is the bone cells from the native bone go in, and they grow into the bone graft that you put in there. So you have to have native bone all around. If you don't, just putting bone powder in there, it's not going to do anything. So this is a very, very important concept to understand, that if you don't have any native bone, no matter what you do, you're not going to get bone growth. There's only one material that will grow bone like that, and it's called infuse, which we didn't use in this case. Here's again the angulation of the implant. This is an implant mount. This right here, this is a mount that comes off and it doesn't stay on. I want you to notice how the implant, because of the angulation, the implant actually comes out in this area here. The threads are exposed. And so we end up growing the bone in this area. We add bone up here just so we have bone 360 degrees all around the implant. I'll show you what that looks like in a second. Here's the graft material. Again, it's human cadaver bone. We put it here, we put some in here, and we fill the void between where the implant is and the bone is. We fill it all. Again, this is human cadaver bone. Usually we soak it with a little bit of patient's blood, and it works really well. And then we actually cover the area, this part of the graft, we cover it with a membrane. And this is what you call guided bone regeneration. So this membrane acts as a isolation of material. It basically isolates or prevents, it's a barrier, it prevents the soft tissue cells from growing into the graft. So it prevents them, and what it does is it allows the bone cells from the native bone grow into the graft. Because just like when you break your arm and they put you in a cast for 6 to 8 weeks, the bone heals very, very slowly, but soft tissue takes 2 weeks to heal and it'll heal up. So soft tissue cells heal much, much quicker than bone cells, and so it's a race against time. And by putting this membrane, a barrier membrane, it allows the bone cells to grow into the graft, and it prevents soft tissue cells from growing into the graft because soft tissue cells grow faster. And so this is a very important concept to understand. This is called guided bone regeneration. So we're guiding soft tissue cells away from the bone. So this is very, very important to understand why we use these membranes. Now, if we don't use it, then the soft tissue cells grow into the bone that we put in, and then it just doesn't even turn into bone. It just turns into some kind of calcium with scar tissue around it. It's not real solid bone. And then we suture everything up. And this area, usually you get quite a bit of swelling here for about a week. This whole area would be very, very swollen, and under the nose almost always swollen. So this is very, very normal. And the swelling really persists. Major swelling is for 3 days. Minor swelling is typically for about 10 days. So this is very normal. These stitches, sometimes they come out on their own. Depends what brand or type we use. Most of the time, if I do it, I use non-resorbable sutures. So meaning you don't have to come back in a week or 10 days, and we'll take these out for you. And her dentist is actually a fantastic dentist. He made her this. This is called an Essex tray. This is a great solution for a case like this. An Essex tray is basically a bleaching tray there's a fake tooth in here. This tooth is fake, but it's a bleaching tray, and it puts no pressure. It's very important that whatever you use, temporary partial dentures, or even an Essex tray, it's very important that they don't put any pressure on the soft tissue that we did, because otherwise you'll run into a lot of problems, and sometimes the wound opens up and then the graft that we did fails. So her dentist did a great job. I'll link her dentist below in the description. They're here in Cypress. And this is an x-ray of this area 4 months after surgery. And as you can see, the bone that we put in there, you can kind of see it in here. It actually grew over the implant, and the soft tissue is here. The implant is actually buried. And this implant is buried for typically about 3 to 4 months. There's something called osseointegration. And what it is bone cells actually grow and they bond chemically to the implant. Now, osseointegration takes roughly 12 to 14 weeks. So I usually wait 3 or 4 months before we uncover this implant and use it. But once that integration happens, this becomes solid. It becomes integrated to the bone, and then it becomes a mechanical piece. And I'll show you what it looks like once the patient goes see the general dentist. So this is clinically what it looks like. So I'm done with a cartoon picture. This is actually the case, exact case. The tissue looks very, very nice. It's a very thick tissue. This is what you call a thick biotype. So thick biotype patients tend to do extremely well with procedures like this. And underneath all this, there's actually an implant under this tissue. And so what we do is we numb up the gum, numb it up, and then we'll do a little punch biopsy here to expose the implant, and I'll show you what that looks like. That's what it looks like. We basically have a circular punch. We remove the tissue, and you can see the threads. This is a cover screw. You can see that in here. We take it out, and we put a very tall, it's kind of a screw, it's called a healing abutment, and that's what it looks like. And then the patient will go and see their general dentist. Now, general dentists will take impression of this entire area, and they'll make this patient something called an abutment and a crown. This is not this case, but very similar. This is what an abutment looks like. This has happened to be a zirconia abutment, and you can see that it's made out of very, very hard glass. That's what zirconia is, and it looks like somebody prepped a tooth for a crown. And this is the screw. The screw screws into the implant. Obviously, this is a stone cast of a patient's mouth. Here's another view of this abutment. That's what it looks like. Just wanted to show you. And this is the case. This is, I saw her about a year later for something else, but then I ended up taking an x-ray. As you can see, this is the implant that we put in. It looks very nice. This is the dental implant. The abutment that the dentist did is right here. This happens to be zirconia abutment, kind of like what I showed you earlier. I made it hard. It's basically very, very hard zirconia. And there's a little screw in here that screws into the implant. And then on top of this, the crown is cemented. So there's really 3 parts to the implant. There's the implant, the titanium implant that's integrated into the bone. There's the abutment, and the crown is cemented. And the abutment and the crown, these 2 parts are done by the dentist. This is typically done by the surgeon. And this is what it looks like clinically. What's important here to note is a couple things. Because she has a very high smile line, it is important that we actually have really nice soft tissue. And as you can tell here, this area and this area, this is called the papilla. She has very nice papilla. In somebody who doesn't have enough tissue, sometimes we have to grow the tissue first before we actually even do the implant, or even sometimes bone grafting, because this is important. Otherwise, people will have a black triangle in this area. They'll have, when they smile, they'll have a black triangle here and here. The soft tissue is not very well developed, and it looks very, very unaesthetic. So this is a picture of this implant a year after it was restored. So it looks very nice, very healthy. There's no redness. Very nice job done by the dentist. And here's another example. Here's another view of what this implant looks like. So the other thing I was going to tell you that you need to be aware of, there are times where you come in and this is a very, very thick biotype patient. So this area of the tissue, this is called attached tissue. This tissue that's really loose is called unattached tissue. Now this patient has very thick attached tissue. Now this is very, very important. Very thick or a thick biotype. A very thick biotype patient is very forgiving. So meaning you can have a pretty unskilled surgeon and they still end up doing really well and looking good. What gets a lot more complicated or a lot more tricky are patients who don't have a lot of attached tissue. If they don't have it, so we have to grow this tissue first. So sometimes we take tissue from the palate here and transport it here to thicken up the tissue, or what we do, we change the biotype first, and then we do the implants and the bone grafting and all that, or sometimes we do it together. And hopefully I'll have some pictures for you guys so you can kind of see the process in a few more episodes. So I hope that explains it. If you have any questions, please leave some comments, and visit our website if you have any issues, or if you're not in Houston. I hope this is a great reference for you. You guys have a good day.